We're here at the behest of the BSH as part of the BSH 60th anniversary celebrations, and this is part of a series of interviews of past presidents of the BSH. I'm very honoured to be asked to be the interviewer in this setting. My name's Pip Nicholson. I'm a haematology registrar in Birmingham, and also part of my time is as a clinical lecturer in haematology. And I'm very pleased to welcome Cheng-Hock Toh. Cheng-Hock, are you able to introduce yourself?
I'm a haematologist based at Liverpool. I was the immediate past president of the British Society for Hematology, and we're sitting in the gardens of the Royal College of Physicians in London because I'm the academic vice president here. After medical school, it was a career that was really quite deliberately targeted at becoming a hematologist, and also probably to explore how much academia I could absorb into that role. Unfortunately, I landed up in Liverpool as a clinical senior lecturer with an honorary consultant hematology post. And I just look back at those 26 years in Liverpool with enormous satisfaction in terms of patient care, the service delivery, the academic outputs, and the other things that have come along the way.
So it sounds like that your decision to be a haematologist was very early on in your career. Is there any particular thing you attribute that to, as to why haematology so early?
But I think we're all influenced during medical school by the placements that we go through, and usually it's the firms that we enjoy most that seem to stick in our minds. I think for me it was probably the elective period in haematology, and I did that at Johns Hopkins University in Baltimore. And really that was a mind-blowing experience for many reasons. But certainly made me think that this could be a career for me. And then I was back in Sheffield doing my haematology placement, and the team that I was working with was so fabulous that I decided I wanted to be a house officer in that team, which I duly did, and never looked back afterwards. So I was lucky in the sense that I knew what I wanted to do quite early on.
It sounds like, as well as haematology being quite an early on decision in your career, from what you said, it sounded like academia was also quite an early on decision. Could you tell us a bit more background about that?
Yeah, I think probably I was keen to think of myself as a researcher in the future, but not quite sure how to get to that. I had always done jobs within academic departments, and the integration between academia and clinical was really quite seamless, and I liked that. But my decision to actually take an opportunity to do research was, again, one of those serendipitous events in us. The opportunity came up. I followed my heart, really, rather than my head, and I took off to spend 2 years at Queen's University in Ontario, Canada. And that was a fantastic time from a professional and personal perspective. I came away feeling that I could also be a scientist in addition to being a clinician. So it was a marrying of skill sets that I think is very valuable, certainly for me.
So it's funny you should say that, because I spent not quite 2 years, but I spent my elective at medical school in Kingston at Queen's University in Ontario. Absolutely loved it there. We've gone into your sort of how you came into your academic career, and we know sort of where you are now, I guess. Would you like to tell us, is there something particular over that time period in your academic career, sort of research output, that you are most proud of?
Yeah, I think I'm particularly proud that I've been able to follow my heart, really, follow my interests, which has always been around the area of hemostatic dysfunction, understanding the coagulopathy of critical illness, the coagulopathy of sepsis in particular. And suffice to say that most people felt that was slightly peripheral to the main research interests in thrombosis and hemostasis. But I stuck to it because clinically I had always felt, even from my elective period at Johns Hopkins, that interested me most. It was an area of unmet need. I still remember the patient in mind. That was a obstetric DIC that was really troublesome, but certainly very intriguing from understanding what was happening. And particularly memorable was sort of points in time when we discovered molecular mechanisms that hadn't been known about before. One example is the complexation between the archetypal inflammatory marker C-reactive protein with very low density lipoprotein, which is also another pretty well-known marker. But when the two come together, they seem to be procoagulant, enhanced thrombin generation. And understanding thrombin generation by different ways has been important to me. And at the beginning of this year, we published in Blood that there is an alternative mechanism of thrombin generation during critical illness, and this time determined by extracellular histone. So for me, those were important contributions to the field, and we will continue to work in that area.
It's increasingly apparent that hematology is, certain aspects of hematology, becoming a sort of consultative specialty and working with sort of liaison hematology, almost working with other medical specialties. And I can see how linking thrombosis and sepsis and is an incredibly important work to do and to understand. Whenever people talk about their research outputs and what they're proud of, it always sounds like it was totally planned and like, yeah, well, this is what I was thinking would happen all along. And actually, I think certainly my experience of research and the clinical career so far is that quite a lot of it is either luck-based or it's actually things go totally wrong and then somehow something good comes out of it. I don't know if you have any experiences that relate to that in particular.
Yeah, I can relate to that. We don't publish our CV of failures. But I cannot imagine anyone's career not having those kind of rejections in terms of the papers that are submitted, in terms of the grants that are written. And I think an important lesson is to realize that you will be lucky if you get 60% of your papers and grants accepted first time around. It is a hard lesson at times, but I like to think of it as resilience building, much in the same way as we learn to be resilient when we start our medical career. If you recall, probably the first patient that didn't do well under your care, I think those things you do learn from it, and I see research as no different from that. And to me, I think those research lessons have also helped me to become a better clinician.
So the BSH has been around now for 60 years, or 61. I guess, what do you think have been the most important advances in haematology within that time that the BSH has been around?
I think haematology has led many, many aspects of medicine in the advancements that we have achieved, both in terms of the successful therapies that we now can offer our patients and the improvement in diagnostics along the way. So certainly during my time as a practicing consultant, the things that have stood out for me has been, for example, HIV treatment. When I was first appointed as consultant in Liverpool, one of the great difficulties was breaking bad news to patients at the time. But over a couple of years, the advancements in highly active antiretroviral treatment really did change the landscape considerably. So that stands out in my mind. Other things that do stand out are the improved thrombophilia tests, not just because it gave us more opportunities to discuss things with our patients, but also in improving our understanding of that balance between pro and anticoagulant forces, coming back to the research interests that I have. I think more recently some of those things have translated into improved care for patients with haemophilia. The new therapies that can enable treatment for haemophilia to be administered once every 2 weeks subcutaneously. That's a huge advancement. And gene therapy is, of course, so pivotal in that too. So many things have improved the care of the patients that I looked after. And I hope they will continue forward. And I think BSH should be proud of these achievements because ultimately we want the best doctors and scientists to be interested in hematology. And over the last 60 years, we know the standout characters that have not only made advancements in individual fields, but also brought teams together and brought that legacy to continually advance the care that we can give to our patients.
So I guess that sort of covers the BSH up to your role as president. And then now you've moved on, haven't you? And I guess that is slightly relevant to why two haematologists not from London are here in the Royal College of Physicians Medicinal Garden. And that sort of leads me on to ask you about your current role, because you are now the academic vice chair of the Royal College of Physicians. To most haematologists, that would seem like an odd move, and presumably there's some logic to it, and it would be great to enlighten people as to what the reasons for that move have been and what you're doing in that role.
Yeah, I can understand why perhaps people might think that it's a slightly different move. If we look at some of the past presidents of the BSH, they have continued their careers in the Royal College of Pathologists. But I like to think that what I'm doing is very much indicative of the move over the past 60 years of how hematology has morphed in it. I remember Victor Hofbrand, a past president of the BSH, telling me that in his time, he was one of the first to have patients actually on the ward. So that was the point where we were transitioning from being a lab-based specialty to looking after patients clinically. And if you talk to most hematologists now, virtually all of them are clinically based, and with probably very little time in the lab. So I think we have been moving towards the physician side of medicine much more. And it's a real honor to be elected to have a senior position at the Royal College of Physicians. The title, of course, is academic, and that plays to another passion of mine, which is integrating research into clinical care, rather than seeing research as separate from clinical care. And if I can really move the dial or reset the dial on that would be really pleasing in my professional career. It is actually very helpful during the times of COVID-19 pandemic and the lessons from it, that we have suddenly seen that research is so important to clinical care. The results from recovery trial, the type of studies that are integrated into service delivery can deliver evidence in such a quick time. So I hope that when we build back better from COVID-19, these are some of the lessons that we need to reintroduce back into clinical care. I think for too long, it's been seen as this or that and one or the other. But the fact that clinicians in small hospitals are recruiting patients into recovery, I think that bodes well for the future of integrating research into care. So if I can contribute to that, I'm happy to say that, maybe a hematologist has contributed from his own professional career to that agenda.
Maybe aside from COVID, because presumably COVID wasn't on the agenda when you perhaps started this role, are there any sort of future peaks that you can tell us about in terms of the particular types of integration of research into clinical work perhaps in other medical fields? Are there any sort of glimpses as to where this is going in the future, aside from COVID?
Yeah, I think certainly COVID has catalyzed certain things, but increasingly it was recognized that because research-active hospitals have better patient outcome, that the NHS trusts and the NHS senior leadership had to find a way of bringing research much more into service. And protecting time for research is important because we're all pretty busy. But there's also the culture piece, the culture that actually research is celebrated. Research is good overall, not just for outcomes, but for job satisfactions. We've surveyed our members, and 2 out of 3 of them tell us that having research as a component within their job plans improves their job satisfaction. They are more likely to stay on in the NHS. They are more likely to go for roles or positions that have research in the job plan. So it's a win-win, isn't it? And I'm hoping that people will start to realize that it's good for everyone.
Mm-hmm. You've mentioned about where, sort of in the academic field anyway, the Royal College of Physicians is going in the future. Might I be slightly cheeky and ask you where Professor Cheng-Hock Toh is going in the future?
Yes, certainly happy to answer that. But I like to think that the future is much more about somebody like you, early in your career. And in my position now, it's very much about making sure that you and your colleagues have the best opportunities going forward. As to what I might wish to be doing after this job, I think an area where I feel I would love to have more experience in is around the social determinants of health, rather than prescribing medicines in the future, which I will leave to the likes of you. This is something perhaps that has been untouched in my professional career. I'm not exactly sure what I wish to do in that field, but I do feel strongly that when we build back better after COVID-19, we do have to address health inequalities. Maybe it's not entirely hematology, but I think whether it is hematology or some other areas of medicine, a lot of our patients are burdened by that. And blood medicine is certainly very important in population health, preventative health. So yeah, that might be something that I would wish to explore further.
And then, if you feel you've not already alluded to this, just to sort of close, we've had 60 years of the BSH. Hopefully we're going to have another 60 years and more of the BSH. Where do you see hematology as a specialty developing and changing in the next 60 years?
Yeah. I think during my presidency, I was very clear that my intention was about shaping BSH to be ready for the future. That it was 60 years young and 60 years going forward was the way we had to look at it. And a strong element in that is to make sure that the membership feels that it values the society, that the membership is diverse, that there's lots of young trainees keen to contribute to the BSH. And I think there has been successes along those fronts. And as to whether hematology will start to diverge slightly, for example, between oncology and non-oncology, we really cannot say. But what I think we can do is to make sure that we attract the very best doctors and scientists into hematology. And although BSH doesn't necessarily give grants or give things to enable that, we should foster that. We should foster that at medical school level, at early junior doctor level, to make sure that people are excited about hematology. And I don't think we will ever be the biggest specialty, but certainly we can always continue to punch above our weight in the kind of advances in knowledge, in terms of making sure that patients benefit from seeing a hematologist.
Thank you. I think we'll probably draw things to a close there, but personally for me, learning that at one time in the not too distant past, haematology was purely a pathology-based specialty and we didn't even see patients. I guess that's naive of me to think that things were so similar to now back then. So thank you for sort of opening my eyes to that, and then therefore the potential to change in the future. I also want to thank you for being so candid in your answers to your questions, particularly when I might have been a bit cheeky, and also particularly for just personal thanks for you and supporting of my career individually and that of trainees in general, with a particular example through your support of HemeStar. So Professor Cheng-Hock Toh, thank you.
Well, thank you, Pip, for this opportunity. And if there are any takeaway messages, I think it's about, being true to yourself, being a good doctor. So being kind, being authentic, and being collaborative. So whether it's to the patient, or whether it's to your team, or whether it's to your discussions with other important stakeholders, if you stick to those three principles, I think success will follow.
Well, thank you.